Hello.
Hello.
Okay. Are you guys able to hear me? Hello.
Yes, sir. Hello.
Hello. Okay. That's great. So you guys are going to be telling me the topics which you guys want to cover. It. I just see a message in the group, and I'll just try my best to cover. Right. So the first one. Okay. Let me just please open the group first. Okay. And let me just see which topics are we gonna do it. So I'm just planning to finish it off. Okay, so complement system, important cytokines, respiratory burst, interferons, vaccination, a few immunodeficiencies. Okay, okay. So let's start from complement system, right? Hello,
Yes.
hello. Okay. So first of all, let me just share my screen. Can you guys just see my screen? Hello,
Yes, sir.
hello. Okay, that's great, right? So first of all, we are going to discuss complement system, right? So okay, so what is the complement system? You should just keep that in mind, right? So the complement system, it basically consists of certain proteins, right? I'm just giving you a basic concept, and after that, we're gonna, build our concept further, and we're gonna go to each and every component, right? Hello.
Yes, sir.
Okay, perfect. So complement system is basically, it's a proteinaceous particle. You can simply imagine of which comes out of your liver, right? Whenever they come out of the liver, they're in the inactivated form. So our body have to activate them, and once they are activated, the complement system basically destroy bugs. That's all. You know, if I want to just if I want to just tell this entire topic in a simple words, I would say that these are basically a cascade of proteins made by your liver in an inactive form. Okay, we have to activate it. We are going to discuss how do we activate it, right? And once activated, they're going to destroy the bugs, right? That's all. The bugs, different things. We'll be discussing each and everything in detail, right? So, okay, what's the main? Okay, let's start the activating pathway. So in order to activate your complement, basically we have three pathways. The first one is classical pathway, the second one is alternate pathway, and the third one is lectin mannose binding pathway, right? So let me just tell you. Okay, till now you guys know that we have inactive form of cascade of protein, and we should activate them in order to get something killed. Okay, so these cascade of proteins can be activated in three ways. Okay, they can be activated in three ways: the classical way, alternate way, and lectin mannose binding sugar. Let me just tell you that. Okay, now while okay, can you guys just see my screen? Hello.
Yes, sir.
Okay. So whenever a microbe enters your body, like for example, this is a microorganism, right? Let's suppose it's an encapsulated bacteria. Let's suppose, right? So first of all, what happens in the classical pathway? Let's discuss how do we activate complement system through classical pathway. So first of all, what would happen? Two antibodies are basically responsible for activating your classical pathway. That is IgG, right, and IgM. We know that IgM is biggest of all. We just discussed the structure, right? So IgG and IgM is going to activate. It's going to attach to the to the microbe which is entering into your body, and through IgG and IgM we are going to activate the complement system. So remember one thing: the main goal of complement system is to activate the C3 component. So we discussed we have different inactive proteins, right? So C3 is going to be that inactive proteins coming out of your liver. And once anything get activated in the complement pathway, it's going to be converted into two things: C3A and C3B. Is it clear? So you should just imagine one thing. The goal of entire three pathways which we discussed, the alternate pathway, the mannose binding lectin pathway, and the classical pathway, their goal is to activate your C3, right? This is a general concept which we should just take in mind, right? So C3, right? What C3 is further going to do, it's going to activate C5, right? The C5. And once the C5 is activated, we know once it's activated, it's going to be converted into C5A plus C5B, right? Okay. This is going to be this is the first important step. This is going to be the second important step in activation of your complement system. And in the end, once the C5 is activated, we are going to get something called MAC, membrane attack complex, right? Okay, membrane attack complex is from C5 to C9. Just keep that in mind. It's very important, right? So, although the complement pathway is like really complicated, right? It's really complicated. Like first of all, C3 is going to be converted into C3A, C4. The C4 is going to be converted. The BB component of them is going to be combined. They're going to form something called C5 convertase. So C5 convertase is going to convert C5. So it's a complicated pathway, but you have nothing to do with that, right? We are going to discuss it, the high yield points, the main concepts. So the main concept is that C3 is going to be the important to activate, right? First, right? Once C3 is activated, the second one is activation of your C5. And once C5 is activated, then we can get something called membrane attack complex. As the name indicates, membrane attack complex. It's going to attack the membrane of the bug, which in the beginning have come and activate the complement system, right? It have to attack the membrane of that bug, because in order to kill this bacteria, first of all, we need to kill the membrane, right? We need to remove that physical barrier. Then it's going to lead to destruction of a bug. Is it clear? Hello? Hello?
Yes, doctor.
Okay. So can
Yes.
anyone just summarize what are the important events, which you guys have to remember in complement? The first one is activation of C3. The second one is C5. C5 leading to MAP. Okay. Hello. Okay.
Yes,
Yes,
doctor.
sir.
So this was basically our classical pathway. Okay. Okay. Let me just summarize this. Summarize this. Whenever a bug enter into your body, your IgG and IgM is going to activate your complement system. The main thing is your C3. The second one is C5. In the end, you are going to have a membrane attack complex from C5 to C9. That's going to come. It's going to attack the membrane. It's going to kill the bug. That's the entire story, right? So it was a classical pathway. The next one is lectin mannose binding pathway, right? So mannose basically is a sugar, right? Mannose basically is a sugar, and this sugar is basically sometimes present in the cell wall of a bacteria, right? So sometimes whenever the lectin and this mannose sugar combine, it can activate the same thing, the same pathway, same thing, right? Same pathway, same thing. Keep that in mind. So what's the difference between classical pathway and what's the difference between mannose binding lectin pathway? The difference is the mode of activation. Classical pathway is activated by IgG, IgM. Are you guys getting me?
Yes, doctor.
Okay, and how do we activate the mannose binding lectin pathway? It's going to be activated whenever the mannose and lectin binds to one another, right? And the entire process is going to be same. That is C5 into C3. C3 activation. The other one is C5 activation in the iron membrane attack complex and killing, right? The last one is alternate pathway, right? What's alternate pathway? Let me make that really simple for you guys. Alternate pathway is the spontaneous conversion of C3 into C3A and C3B. We do not know the reason. Sometimes C3 converts spontaneously into C3A and C3B, right? And we are going to be having something called factor B, right? Factor B. So these two things are important for alternate pathway. The spontaneous conversion of C3, the spontaneous activation of C3 along with factor B. Keep that in mind, factor B, right? Because in some MCQs you are going to, get this like they're going to ask you, we have a complement activation. How do we know the complement is activated? We look towards C3 and C4 levels, right? If they are decreased, we know that the complement is being used, right? Okay. So they're going to tell you that the C3B is constant, the value is constant. It means that it isn't an alternate pathway, because the alternate pathway is spontaneous conversion of C3 requiring factor B. That's all. That's all. Okay. So once we have spontaneous conversion along with this factor B, it can again activate your C5 and it can activate your MAC complex, and again the entire pathway is same. Is it cleared? Do you guys have any questions? Hello?
Yes,
Hello?
sir.
Do you guys have any questions till now?
No, doctor.
Hello? Okay, perfect. Another thing which you should just keep in mind, you guys might have done the hypersensitivity reaction with Dr. Moaz, right? So there was a hypersensitivity reaction called, hypersensitivity type 2 reaction. What happened in type 2 reaction was antibodies were directly going, they were attaching to the surface of a membrane, and they were just calling upon your complement system to come and please destroy this thing, right? that was IgG mainly, right? Hello, hello.
We are hearing
Okay.
you.
Okay. So if it's being activated by IgG, what do you think? Which pathway is it? Alternate, classical, or Manners binding? Like
Classical.
Classical.
classical, right? Okay, classical pathway. Okay. And if you guys remember in type 3 hypersensitivity, what we discussed that it's going to be due to immune complexes deposition, right? The immune complexes are going to deposit, right? And we discussed it is the goal of your complement system to kill this complement to the immune complex, right? If the complement system fails to clear this, immune complexes, we are going to be having a lot of problems, right? If you have, problems with the complement system, not destroying your immune complexes, that's going to lead to type 3 hypersensitivity. It's going to build up in case of SLE, in case of post-abdominal nephritis. We know that it's going to build up, deposit in the tissues. In the tissue, again, the local complement system is going to be activated. But since the local complement system cannot destroy these things in the first place, so they would start destroying your tissues. That complement would start destroying your tissue. How? How? Which markers are important for bringing your neutrophils to cause destruction and everything? We're going to discuss that in a while. But till now, is this general concept for a complement system? Is it clear? Hello?
Yes, doctor.
Perfect. Okay. So here you guys can see, right? Okay, I'll just read the first set and you guys are going to understand each and everything, believe me, right? Okay. Okay. Before this going into the first set discussion, let me just mention a really important thing as well, right? Before going into that. Remember, okay, for example, if this is my red blood cell, right? Okay, it's my red blood cell. You know, the complement system, the proteins also roam around here and there in the blood, right? Is it right? Hello?
Yes, sir.
Hello? Okay.
Yes.
It also keeps on roaming around here and there in the blood. It means that the red blood cell have very destructive kind of neighbors, right? The complement system. So for that purposes, your red blood cells must be having something to, you know, to save itself from the complement system. And what are they? It has something, the pillars kind of structure. And on the top of them, they have something called DAF and CD55. We are going to discuss that. And these things are responsible for saving your red blood cell from these destructive neighbors, complement system. Is it cleared? Yes or no?
Yes,
Yes.
doctor.
Perfect. Right? So for example, for let me just give you an example. Let's suppose if you do not have this pillar, the GPI anchoring protein. So now what would happen? Now the complement system can easily destroy your red blood cell, right? Hello?
Yes, doctor.
Okay. Perfect.
Yes.
Okay. For example, if you do not have that DAF, decay accelerating factor, which is going to decay the activation of your complement system. Again, we are going to be having destruction of the red blood cell, right? And what's that pathology called? P and H, paroxysmal nocturnal hemoglobinuria. But let me just clarify that concept in detail. Why have we named it as PNH, paroxysmal nocturnal hemoglobinuria? There is a big concept in it. What do you mean by paroxysm? Do you guys have any idea? Please just
Ep-
keep this session
Episodic.
interactive. Episodic, right? Please just keep this session interactive because I want to, clear a lot of things today. Okay. Okay. So, episodic nocturnal hemoglobinuria at night is going to be having
Yes.
hemoglobin coming out of the red blood cell. Hemoglobinuria basically indicate that red blood cells have been broken down, they have been killed, so that's why the hemoglobin is released, right?
Yes.
Yes,
Hello?
doctor.
Okay. So why, especially at night, we are having hemolysis? That should be your question, right? Hello?
Yes.
Yes, doctor.
Yes.
The reason is that at night, once we sleep, we are going to hypoventilate, right? We hypoventilate. The respiratory rate go down, right? And as we hypoventilate, what would happen to the level of carbon dioxide in the blood? It would rise.
Increase.
It would
Hyperkalemia.
lead
Increase.
to acidosis, right?
Mm.
Yes.
Remember, acidosis can activate your complement system. It would
Yes.
activate your complement system. And since we do not have these particles to save your red blood cell from the complement destruction, the red blood cells are going to be destroyed at night. So once this guy with absence of DAF and anchoring protein, it's going to be our entire pathology which we'll be discussing, right? So once they wake up, they just go for their pee, right? They're going to their urine is going to be dark, indicating that they have hemoglobin in the urine, right? So that's why we call it as paroxysmal. Sometimes why? Because as he sleep, he create acidosis, a favorable environment for complement activation. Nocturnal at night, hemoglobinuria. Once he just wake up, he's going to see hemoglobin in the urine, indicating hemolysis. Is this concept clear?
Yes, doctor.
Okay. Let's discuss another thing. That's really important. A lot of keyword MCQ, you guys are going to see. Okay, we have something. Okay, we know inside our body we have some regulation as well, right? In order to avoid exaggerated response, exaggerated activation of your complement system, what do we have? We have something called, okay, the first thing which will activate is going to activate is C1, right? Once the C1 is activated, then you're going to be having these processes going further, right? We have something called C1 esterase inhibitor. So in some cases, if it's a regulatory kind of protein, you can simply imagine, right? So if we have exaggerated activation of the complement system, your C1 esterase inhibitor is going to, you know, inhibit the complement system because it's an exaggerated way, right? Is that clear? Hello?
Yes.
C1 esterase. But what's the other function of C1 esterase? That's also really important, right? C1 esterase, we discussed, inhibitor is going to be inhibiting your complement system. And that way, it's going to regulate if the complement system is exaggeratedly activated. Is it clear? But what's the other function? It degrades your bradykinin as well. It degrades your bradykinin as well. So if someone is having deficiency of C1 esterase inhibitor, he'll be having something called hereditary angioedema, right? Why? Because they cannot degrade the bradykinin. Bradykinin once accumulated, there's a good vasodilator leading to angioedema. And what do you mean by angioedema? Angio mean blood vessels, edema mean fluid moving out of your blood vessels. Due to vasodilation, that can happen, right? Bradykinin can cause vasodilation. How do we have accumulation of bradykinin? C1 esterase inhibitor, but you guys already know we discussed ACE angiotensin converting enzyme also do the same function, right? It degrades bradykinin. If you guys remember one of your UWorld MCQ, right? What was that? An individual was on ACE inhibitors. He developed a protective cough. We switched him to ARBS. Why? Because the bradykinin. So an individual with C1 esterase inhibitor, you cannot even, you'll just tell him don't even go close to ACE inhibitors. Don't even go close to, like, taking in ACE inhibitors is something else, and advising him not even, looking towards that medication is another thing, right? Because he can suddenly develop angioedema. You already have increased baseline level of bradykinin. Is this concept clear? Hello?
Yes.
Yes, doctor.
Okay, so
Yes.
in the UWorld, how are they going to test you? You know the basics. They're going to be telling you, we have a boy, he develop, facial puffiness, everything which indicates angioedema, right? What will be happening to C4 levels? What do you guys think? C4 will be increased or decreased?
Will be decreased. Will be decreased.
It would be decreased. Why? Because you have no one to inhibit your complement system. Complement system is going to be exaggeratedly activated. So you can, in this way, you can connect the bradykinin angioedema with C1 esterase inhibitor. The other function of C1 esterase inhibitor is to inhibit your complement system. And we know in order to check the activity of complement system, we look towards C4 and C3 and C4 level, right? If they are decreased, it means that complement system is activated in exaggerated way or manner. Is this concept clear?
Yes.
Yes,
I
Okay.
have a doubt, doctor.
Yes,
Can I
please.
ask? I have a doubt in that paroxysmal nocturnal hemoglobinuria.
Yes. Mhm.
It's not needing any antibody to get activated. It's that lysis
Okay.
complement doesn't need antibody there.
Okay. Let me just tell you simple. Let me
Okay.
just make it
Okay.
really simple. In order, okay, complement system and red blood cell are neighbors, right? You know what is the complement system are destructive. They destroy things. If you have a neighbor, let's suppose if you have a neighboring some neighbor, right? He is destructive. He always fire on people, right? So for your safety purpose, obviously you have to do something. You have to, you must be having some weapons, right? So in that way, he's going to be afraid that do not attack the red blood cell because he have weapon. But if you do not have weapon and they are destroying your neighbors, he's going to destroy you as well, right? Because he know He have nothing. He have nothing to defend. The red blood cell now have nothing. So this is basically your defense of red blood cells. The DAF, the anchoring, right? We're going to be discussing that in the hematology section in detail, right? But at night, the complement system became activated. It would just say, let me just destroy things because I have acidosis. The environment is really favorable for me to destroy things. Red blood cells, you do not have any, now in this case, in PNH, you do not have any, anything to save him. Let's destroy him. That's all.
Okay, so here the trigger for the complement is acidosis, not any.
Acidosis. No,
Okay,
nothing
okay.
else. Nothing else. Acidosis is going to be the triggering event, and the red blood cells are being destroyed because they do not have any, anything to save them. The DAF, they do not
Defensive.
have DF, right? So let's discuss it from our first year, right? Okay.
Thank you. Thank you.
Okay, you are welcome. Thank you so much. Okay, so you can see hepatically synthesized plasma protein. We know these are something being made by your plasma by your liver, but inactive. They are going to be converted into active form. How? By some kind of paths, as we discussed macros. We have classical alternative lectin. The classical require IgG, IgM. IgM is the biggest of all. That's why you can easily activate your complement system. Okay, and IgG as well. Okay, so here you guys can see this picture. Okay, so we have these alternate pathway, the classical and lectin, right? So all of them is going to activate your C3, C3AB, the C4AB, just and you're okay. C3 convertase do that, right? Then you're going to be having C5 convertase, and the end you have membrane attack complex. Is going to be from C5 to C9. That's all. And the highest things which you should just the take home points are these. C3B is a good option in one of your really high yield MCQ. Okay, C5A, C3A, and C4A are your anaphylaxis. They lead to anaphylaxis. What is anaphylaxis? You guys know that dumping, histamine, vasodilation, anaphylactic shock, and everything, right? C5A are neutrophil chemotaxis. They lead to neutrophil chemotaxis. So along with MAC, they just call upon the neutrophils also to destroy things, right? And C5B to C9 is your membrane attack complex. We already discussed that, right? C3B, opsonin. C3B, what is opsonin? You guys know that. Opsonin is anything which help you attract a lot of immune cells to the site. Is it clear? Hello?
Yes.
We discussed the inhibitors, the DAF, the CD55, and C1 inhibitor. We discussed that, right? C1 esterase inhibitor. Okay, so the DAF, CD55, GPI anchoring, right? The anchoring, you should just keep that in mind. That the DAF and CD55 are not directly attached to the red blood cell. They need some anchor, they need some pillars. They need some pillars. And upon that pillars, you're going to be having DAF and CD55. If we even do not have those pillars, again, it would lead to PNH. Keep that in mind, right? For C1 esterase inhibitor, we discussed is going to inhibit your complement system, but what's the other function? Degrading your bradykinin. If you have deficiency, it's going to lead to, angioedema, hereditary angioedema. Is it clear? Hello?
Yes, doctor.
Okay, so we can have two kind of complement deficiency, early and terminal. That's really simple. The early involve, okay, we have C1, 2, 3, 4, 5, 6, 7, 8, 9. So which one is the earlier? The early one are C3, C1, C2. You can just imagine, right? And the terminal in the end are C5, C9, those things, right? So if we have early complement deficiency, the C3, it means you cannot activate your complement system. If we cannot activate in the complement system in early deficiency, we are going to get something called SLE, systemic lupus erythematosus, right? Okay, we are going to discuss SLE in detail. Okay, that's a pathology. Do you guys want me to discuss SLE now a little bit?
Yes,
Yes,
sir,
please.
please. Please.
Yes.
So for that, you have to, just stay a little bit, patient because it's. I want to discuss the entire, micrological details of this. Okay, remember, if you have someone, okay, for example, if I have an individual, right, and the sunlight fall on his skin, the UV rays are really toxic. You guys know that they can hit your DNA, right? Is that clear? Yes or no?
Yes. Ultraviolet B
For example,
rays.
if these are your cells, the DNA can be hit, right? The chromosomes, chromosomes contain the genes contain the DNA and everything, right? And once the DNA is hit, the cell is going to die, become dead, because it's your nucleus, it's your chromosome. It's basically lead to the survival of cell. Once they are dead, it means that they are going to undergo apoptosis, right? I'm just talking about a normal individual, right? Hello. Okay.
Yes.
Okay. Okay. Once they become apoptotic, we are going to discuss karyolysis, karyopyknosis, and karyolysis. That's are going to be the process of apoptosis. For the apoptosis, we are going to discuss in our general pathology. We have two pathways: the BCL2, if you guys remember, and the other pathway is the fast ligand. Remember the fast ligand. So these two pathways can activate your apoptosis. Do you want you got okay? Let's discuss that as well. Okay. Okay. So, for example, whenever you have a cell, just keep one thing in mind. You have your mitochondria, right? In the mitochondria, you have something called BCL2, right? Normally, the BCL2 is stuck within the mitochondrial membrane. It's stuck within the mitochondrial membrane. Okay, and we won't ever, tell the BCL2 to leave your location and get into the cytosol. But if it happens, what would happen? The BCL2 come to the cytosol or the cytoplasm, it would lead to activation of protease. It would lead to activation of, a lot of enzymes, which can just kill your cell. So for activation of apoptosis, apoptosis is basically killing of the cell, right? We can, okay, how do I kill the cell? I'll just tell the B cell to just go into the cytosol, activate the enzymes, and in that way I can just kill a cell, right? So this is the one way how do we activate apoptosis. Is it clear? Hello?
Yes, sir.
Okay.
Can you
So,
repeat one more time, please?
okay, this is your cell. In the cell, you have your mitochondria. In the mitochondrial membrane, we have something called BCL2, right? Okay. So simply, you can just imagine that these are some mad dogs, mad kind of dogs, and we have just imprisoned them. We have imprisoned them. We aren't allowing them, right? Okay. If you just allow them to go out, those dogs are going to eat everyone, right? They're going to bite everyone, right? So BCL2 are mad dogs. We have just imprisoned them in that membrane, right? But if I need to kill this cell, what would I do? I would just let these dogs go out and eat this entire cell. That's apoptosis. Is it clear now? Hello?
Yes, doctor.
Okay. So we discussed in SLE normally. Okay, we were discussing in normal individual, right? So normal individual, sunlight fall, UV rays, it knocked off your DNA. DNA is knocked off. What happens next? The cell is going to undergo apoptosis, right? Apoptosis, like you can simply imagine of the dogs are being released, the mad dogs are released. They kill the cell. But as the cell is killed, so it will just release all of its DNA, right? DNA, for example. So we have to clear the debris as well, right? You have killed the cell, it's left with some debris, right? Like if you just, we kill someone, we have to bury them, right? So we have already killed this, this cell. So in order to, remove the DNA which have been moved out of the cell due to killing of the cell. So how do we clear that? That's really easy. The IgG is going to come here, and again it's going to activate which pathway? Your complement system classical path.
Classic
Is
path.
it clear? Right? Hello? Okay.
Yes.
So we have these DNAs attached with antibodies, complement system. But what if we have complement deficiency, early complement deficiency? You cannot kill these immune complexes. Now they are immune complexes. Whenever we have antigen attached to antibody, that's an immune complex, right? Hello?
Yes.
Yes.
So if we have complement deficiency, we cannot kill this immune complex. So what would happen? Immune complexes are going to build up in the blood. And as immune complexes build up, they are going to deposit in the tissue. So which kind of hypersensitivity is it?
Type 3.
That's so simple, right? So here we were discussing, if we have early complement deficiency, is going to lead to, yes,
SLD.
SLE. Can I say that?
Yes.
Yes, I
Yes.
can say that, right? So That's an example of type 3 hypersensitivity. We also have type 2 hypersensitivity in SLE, which we're going to discuss in detail, right, in our pathology, right? Like our SLE is going to involve 13 systems of your body, 11 systems, 11, right? Starting from the skin, the kidneys, the heart, serosal surfaces, and everything, even your brain and everything, right? Okay, but one thing which you should just keep in mind, how to, what's the, the test for diagnosing the SLE we know that's anti-DNase antibodies, right?
Yes.
It's really hard for someone, some students to remember, but this is the concept, right? Anti-DNase antibodies, right? Okay.
Anti-nuclear factors.
Yes. Okay. But we also have something called drug-induced lupus. In that, we are going to be having anti-histone antibodies. So, what are histones? That are really simple. So if this is your chromosomes sometimes have some proteins called as histone proteins. So those histone proteins can sometimes come out. Antibodies can be present against those histones. Since we have early complement deficiency, it cannot be cleared. We have type 3 hypersensitivity, right? But that antihistone is more seen in drug-induced and lupus. With the drug project HIP, that's the name of it, right? Hydrazine isonazate and procanamide, right? Hello.
Yes.
Okay, is this concept clear? Okay.
Yes, sir.
Okay. So for Neisseria infection, like we have two Neisserias, right? Bacteria, meningitis and what else? Gonorrhea.
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 Gonorrhea. In order to clear them, again, we need complement system. But if someone is having terminal complement deficiency, terminal was your MAC, right? Membrane complex, right? Hello?
Yes.
If you have early, it's going to lead to SLE. If you have, terminal, not formation of the membrane complex, these two bugs can dominate. They can cause problems, right? Is it clear?
Yes, doctor.
Yes.
What were the bugs? Neisseria and
Okay, Neisseria. Neisseria meningitis and Neisseria gonorrhea, right? Okay, so you guys can see it here. I think everything is clear. Let's just read it now, okay? So early complement deficiency, increased severe, recurrent pyogenic and sinus and respiratory tract infections. C3b used in the clearance of antigen antibody complexes. Now you know why C3b or C3b attracts your. That's a good. Okay, what was C3b doing? That was a good option, right?
Oxygenating.
oxygenization.
Option. That's perfect.
Yes.
If you have terminal, increased susceptibility to Neisseria bacteria. Okay. C1 estate inhibitor, hereditary angioedema. You guys know that. Do not even, tell them to go close to that. Paroxysmal nocturnal hemoglobinuria. We know that. Anchor proteins, not EAF, not CD55. In the end, we have, okay, it isn't mentioned in the first year. Okay, one thing which you should just keep in mind, that's second point, right? So in PNH, we discussed that the red blood cells are going to be destroyed at night events. We have acidosis depletion of complement system, right? Once the hemoglobin come out into the blood, we have something called haptoglobin. Do you know what is haptoglobin? Because hemoglobin once come to blood can cause a lot of problem. It can cause a lot of problem, and I'll be telling you what problems can it cause. It can lead to coagulation. It can activate your coagulation cascade, right? It can lead to a hypercoagulable state. Okay, it can destroy your kidneys if you guys remember. We discussed acute tubular necrosis, right? Myoglobinular crush injuries, hemoglobin. It can directly destroy your kidney, leading to back pain with hemoglobin anemia, right? Okay. Is it clear? Hello?
Yes.
Okay. So inside your body, you have haptoglobin. What's the function of haptoglobin? Haptoglobin, catch all of the free hemoglobin because hemoglobin is very toxic in the blood. So my question for you guys is, if you have hemolysis, what would happen to the level of haptoglobin? Decrease or increase?
Reduce. Reduce.
Increase or
Reduce.
decrease? Reduce because they have
Decrease because they are
they
captured,
have
bind with the.
they have captured all of the hemoglobin. They have captured their numbers. Free haptoglobin is very less.
They're
Is this
used.
concept clear?
Yes. Yes.
Excellent.
Hemoglobin.
So this was all about complement system, right? Okay. So is this topic being taught, or I should just go to this one? The cytokine.
You can go through it.
We can go, yes, because it will be more clear than the concepts.
Perfect. So let's discuss. Okay, interleukin 1, 60. Okay, first of all, you should know what things come out of the macrophages? Let's study about, right? Macrophages. Macrophages can be your antigen presenting cells, right?
Yes.
Yes.
Okay. What things come out of macrophages? What things come out of T cells? What comes out of Th1 cells? What comes out of your Th2 cells? And what is the function of that? Okay. Interleukin 1. Okay. Okay. So we discussed, okay, you guys are going to be telling me one thing which I just, repeated again. For example, if an extracellular organism comes, the antigen presenting cells are going to be coming, right? They're going to engulf them, right? And one of the antigen presenting cells can be your macrophages. You guys know that, right?
Yes.
What happens next? Please tell.
It will present it to the MHC class 2.
Then
And then with the T, will activate the T cell. Will have the interaction with the T helper cells.
Okay.
TD4T.
we have two pathways.
Two pathways. T helper cell 1
macrophage.
and
Yes.
T helper
Where
cell
to go?
2.
Okay.
Yes.
It's TH1 and
Th2.
TH2.
we know that in order to get TH1 activated, macrophages are going to come for TH2 B cells are going to. Let's be more specific. Okay. If this macrophage want me to activate TH1, it means it have to send something, right? And if the same macrophage want me to activate TH2 again, there is going to be difference in the messaging system, And we know that interleukins and cytokines are your messengers, right? So if I want to activate my TH2, so the macrophages are going to dump something called interleukin 12,
Interleukin 4.
not 12. Okay? If
Right.
I want to activate TH2, the macrophages is going to dump something called interleukin 4. Is this concept
yeah.
clear? Yes or no?
Yes, yes, clear.
Yes. Yes.
Because we did need okay, from the same lineage, if you are getting two things, it means you have to guide them. Either I need the first one or second one. How do I guide them? With specific messenger. If they get IL-12, they are going to give me macrophages. If they get IL-4, they are going to give me. So that makes sense, right? Or what happens next? It's going to activate TH1. TH1 is going to recruit macrophages. Another thing, macrophages again would dump IL-12 because here the antigen presenting were the same macrophages dumping IL-12. So it means that IL-12 is coming from the macrophages. Am I right? Yes or no?
Yes. Yes.
And what this interleukin 12 would do, it would just come here, the TH1. And to just tell them that I need more activation of mine. I need more macrophages because you just make macrophages. Look, it's 12. It's 12. Just make more macrophages, right? Does that make sense?
Yes. Expansion of colonies only.
Okay. Yes. So what TH1 is going to do is going to release something called INF gamma. Right? Hello? INF gamma is going to act again on macrophages, again dumping of IL-12. So a vicious cycle is going to begin, right? But INF alpha gamma is also going to go into the other sites activating your natural killer cells and CD8 positive cytokines. Is this concept clear? Hello?
Yes.
Okay. Interferon. It means interferon gamma is coming from TH1, right? Okay. So again, in inflammatory processes, for example, if this is granuloma formation in TB, there's going to be inflammation, right? And whenever we have infection and inflammation, we are having fever, right? Okay. How do we get that fever? Macrophages would dump IL-1 for that. IL-1 is going to go into the hypothalamus. It's going to, set the temperature point. It's going to cause fever. Because fever is also, a line of defense. In order to fight off your bacteria. Because in increased temperature of your body, it would be difficult for your bacteria to make, proteins are going to be up. Is this clear? Hello?
Yes.
We discussed IL-4. From where the IL-4 was coming? From the same macrophage, right? Activating your TH2 receptors, activating your B cells. Okay. So let's read the first. What first is just telling. So the IL-1 basically, okay, what else? If you guys know that, for example, right, let me just give you this concept and then we are going to move to the first step. For example, if this is a tissue, right, any kind of tissue, and let's suppose if you have a cut over that tissue and some bacteria enters into that cut. We know that in acute phases, the neutrophils are going to come here, right? Hello?
Yes. Yes.
Okay, so how do the neutrophils come? That's really interesting phenomenon, right? The neutrophils are going to come, first of all, in order for these neutrophils to come here to the site of infection, as they are moving fast, so first of all, they should slow down, right? Right?
Yes.
Okay. Then what should happen? These neutrophils should move towards the periphery here, right? Hello?
Yes.
And then we have some adhesion molecules which would just, catch these neutrophils and it would just take it here to the site of infection, right? So these adhesion molecules are really important to catch your neutrophils and get them into the site of infection, right? We are going to discuss a pathology. If we do not have these adhesion molecules, what will happen? We won't create pus. It will be difficult for us to separate the, the like you guys might have done that yesterday, right? You guys have did the pathology, right? No?
What?
The adhesion molecules deficiency. Okay, just
Yes.
keep this in mind, right?
Yes.
So it would just, take the neutrophils to the site of infection. So what okay, let's just come here. What IL-1 does, IL-1, first of all, is going to cause fever. We know that, right? What else do it do? It increases the endothelial, okay, both IL-1, IL-6, and TNF alpha. TNF alpha also comes from your macrophages. Both of them are going to cause fever, right? All of these three. And all of these three things are going to increase that endothelial adhesion molecules to get neutrophils to the site of infection. Is this concept clear? Hello? We're going to be having an MCQ in your NBME, right?
Yes.
But they're going to ask you that we have an individual with osteoporosis, right? In osteoporosis, we know we have exaggerated activation of osteoclasts. And we know osteoclasts are same macrophages, but within the bone, right? Hello? Hello?
Yes.
What? How do we activate those osteoclasts? Again, interleukin 1, also called osteoclast activating factors. Keep that in mind, okay? Then, okay, interleukin 6 and TNF alpha, all of these three things cause, fever. Along with that, they increases the, the adhesion molecules to get neutrophils into the site of infection. What IL-6 do, it also, increase the acute phase reactants. What are acute phase reactants? Every chronic, disease, we have something called acute phase reactants that are the inflammatory markers that are coming from your liver, right? Keep that in mind. Interleukin 6, not interleukin 6, right? Acute phase proteins from your liver. Keep that in mind. Very important, okay? For IL-12, we discussed. If we need Th1 response, we're going to have IL-12, right? Am I right? Hello?
Yes. Monotrophy.
Okay. For IL-4, I'm going to discuss that. That's not basically going to come from your macrophages, right? That won't be coming from macrophages. That will be coming from your B cells. Because we discussed, okay, for Th1, I just told you it can be macrophages. But B cells can be your antigen presenting cells. Remember? Hello?
Yes,
Yes.
sir.
B cells
Yes.
can be your antigen presenting cells.
Yes.
Those B cells, once drop your interleukin 4, are going to activate your Th2 response. Keep that thing in mind, right? And another really important thing which we're going to discuss in vaccination is just write it down. It's the basics of your vaccination, right? MHC class 2 only load peptide antigens. Only load peptide antigen on its surface. Only load peptide antigen on its surface. If a foreign particle or a foreign microbe is having peptide compound, MHC2 is only able to load that. So can I say that if we have peptide antigen, then we can have antigen presenting cells, then we can have a Th2 response. If we do not have any peptide antigen, we cannot have B cell, okay, T cells dependent B cell activation. Is this concept clear?
Yes, clear.
Yes,
If
PM.
we have peptide antigen,
Doctor, can you
Can
you
you
please
repeat
repeat?
it one more time?
or no problem. We discussed we have antigen present itself, right? It have MHC class 2. And I just told you it's going to engulf an antigen and present it on the surface. But it can only break the peptide component of a pathogen and it can load into the surface, only peptide. Once it just come down, interact with CD4, for example, if it's a B cell antigen present, it's going to dump off interleukin 4, right? And it's going to give us, interleukin 4, Th2 pathway, right? And it's going to give B cells and some memory B cells. These B cells are going to make IgG, right? And IgG are basically really important for your memory, for your vaccination, right? Hello? So can I say that only peptide antigen can cause pH-dependent activation of B cells? How do I activate these B cells? The activation of these B cells were dependent on these T cells, right?
Yeah.
It's basically T dependent activation of B cells, pH dependent activation of B cells. Can I say that?
Yeah.
And only
Yes.
peptides can do that, right? Okay, let me just finish off this story here, right? So, for example, if I'm just giving a polysaccharide, okay, how do we activate B cells? That's really important. B cells can be activated in two ways, either TH dependent, as this entire story you guys know, and T independent, right? If we have TH dependent activation of B cells, then we can have the class switching IgG. IgG is already good for your, for your memory response in future, right? But if we have T, how do the B cells get, activated without the help of T cells? Remember, the antigen would just come to the B cells and it would just dump IgM only. IgM only. Okay, no IgG, because for the IgG production, we need we need what? What do we need? We need TH
Class
dependent
switching.
activation. Class switching need TH dependent activation. Am I right? But if we have a non-peptide antigen, it will directly dump off the IgM from the B cell, because we know that the B cell can only make IgM, right? If you do not have any class switching. Is it clear? Right? So, hello?
Yes.
Okay. So let's suppose, let's take the same Neisseria infection, right? The Neisseria one. It have capsule. The capsule is made up of polysaccharide. If I just give that polysaccharide to someone, right? So it's only going to undergo this, right? That is TH independent B cell activation. It's only going to give me IgM. Am I right? So
Yes. Yes.
IgM is not good for your immunity, right? For the long-term immunity. IgG is good for that. IgG is, more clever. Right, so that's why I'm going to be giving booster doses, every month, every year, in order to keep them reminding that, what's the concept of vaccination? The concept of vaccination is training your immune cells, getting memory into them. So if we have attack of that organism, so in the future they can fight them off, right? But if we have weak training of B cells, if we have weak training of B cells, it means how to compensate that? You can have two ways to compensate. First of all, you can give some booster doses. Keep on training them again and again. Is this concept clear? What else I can do? What else I can do? I can take this peptide. Okay, I can just take this polysaccharide and I can just combine a little bit protein with it, a little bit peptide. Okay, so I would just take some peptide from, let's suppose, Dr. Jamil, right? And I'll just attach it to them. And it would be a really clever way. Because now it has peptide, it has activation to MHC2, it has activation of pH dependent B cells. It can now give me IgG that can be for a long term. So that's a concept of conjugate vaccines. Why are we just getting conjugation? Is this concept clear?
Yes, clear.
Okay, so immunity and immunology itself is really interesting if you are just connecting them. You're connecting, it's really interesting. Okay. And you don't have to memorize it. Like it's going to be really interesting if you understand.
Doctor, I have a doubt with this
Possible?
polysaccharide.
Mhm.
It says it is not recommended in infancy. Why in infancy we prefer that conjugate over this
or
polysaccharide?
live, or the live or polysaccharide.
Uh, there's a difference table which says that toxoid conjugated vaccines are preferred in infancy and elderly as compared to only polysaccharide vaccines. Is that correct?
Okay. So once we're discussing that entire table, okay, let me just tell you the concept. In infancy, already a baby is immunocompromised, right? So you're going to avoid certain type of drugs, right? Like for example, live attenuated. Why? Because they are actually live vaccine. Instead of training their immune system, you can cause problems, right? So whenever you see infancy immunocompromised, so you should just think of less immunity, less immune cells. They are not competent of getting into training. For some, they are competent for getting trained for some and not for the others, right? Okay, we are going
Yes.
to be discussing that in our vaccination chapter, right? But here you should
Okay.
just okay. But the main concept here is that they're already immunocompromised. You have to be really specific, no, about specific vaccines. Is it
Okay.
clear? Okay.
Yes. Okay. Thank you.
Okay. So this was okay. Okay, we were discussing this interlude. Okay. So the TNF alpha is also really important. We discussed it can just cause here it might get fever substance. What else it do? It maintains your granuloma. Maintains your granuloma. That's something you have to memorize, right? Because TNF alpha is a big, granuloma G alpha. Alpha cells we have glucagon, right? So in this way you can just remember that alpha also maintains your granulomas. Glucagons for granulomas, alpha cells for alpha TNF. Okay? Hello? Okay.
Yes, sir.
And it can release something called cachexin in malignancy. What is cachexia? You guys better know it, right? Thin individual with less muscle mass, with less fat like a cactus, right? Then we have interleukin 8, really simple. It attracts neutrophils, 8 for neutrophils, and for interleukin 12, you guys know the story, right? Hello? Hello?
Yes, sir.
Okay. Okay. Is there any question? Till now? Hello? You guys aren't just taking interest, I think.
No,
No,
sir. Just
okay.
there is two, sir, interleukin. One is for formation of the granulomas, and one is for the maintenance of the granuloma. Just you
Mhm.
can explain this one.
Okay, interleukin.
I think
Interferon gamma and alpha.
That's the
alpha is
TNF
for the
alpha for
formation.
the, yeah, for the
Mm.
granuloma
TNF
maintenance.
alpha is
TNF alpha.
maintenance, right? We
Yes.
discussed the
Yeah,
interferon gamma coming from TH1 making the granulomas
making the
because
granuloma.
granulomas are your macrophages. For the making of granulomas, it's interferon gamma. For maintaining the granuloma, if you have you just if plant something and keep watering the plant, right? So, making the plant is another thing and maintaining the health of plant is another thing, right? So if you are just, making the granuloma, so interleukin 12 as well as your interferon gamma is responsible for that. Because interleukin 12 will tell to your TH1 to give me interferon gammas, right? They'll just make granuloma. And to maintain granuloma, that's CNF alpha. Okay. The T cells are going to release something called T interleukin 2. Interleukin 2. So let's discuss what's interleukin 2 important for. Okay. So remember, interleukin 2 cause growth of a lot of things, right? Interleukin 2 would growth or lead to the growth of T cells as well because T cells have T cells receptor. We know that, right? And along with T cell receptors, T cells also have receptor for interleukin 2. So sometimes your T cell can make interleukin 2, right? It can go to other T cells having the same receptor interleukin 2, right? It can just, attach to the interleukin 2 receptor and it can cause growth of the T cells. Is it clear? Hello? That's going to
Yes.
be a paracrine effect. Paracrine effect, right? If it's leading to the growth of T cells which are present in the para region or the periphery region, that's going to be a paracrine. It also have an autocrine effect. Interleukin 2 can come and act on its own cell to lead to growth. That's an autocrine effect, right? So growth of T cells is your interleukin 2. Okay. So you can see, okay, it would also go to the lymph nodes. There it can lead to, growth of your natural killer cells, cytotoxic T cells, right? Is it clear? There's going to be an endocrine effect, right? So do you guys are you guys understanding the terms which I'm using? Paracrine, paracrine, autocrine, and if they release interleukin 2 into the blood, right? So in the from the blood it would enter into lymph nodes, right? And in the lymph nodes it would lead to activation of T cells there or the natural cell there. Anything moving to the blood is endocrine effect, right? And anything moving to the duct is exocrine, right?
Yes, sir.
Okay. So that's going to be an endocrine effect, okay? So interleukin 3 is really important. It again comes from T cells. And what would it do? It would lead to, hematopoietic stem cell differentiation. That's a big topic of our hematology, right? Erythrocytes, granulocytes, granulocyte contain basophils, eosinophils, monocytes. That's a topic of hematology, right? So for the hematology, 3 is really important, interleukin 3, right? Is it clear? Hello?
Yes.
Yes, sir.
For the interferon gamma, we know that it's being released by your Th1 cells. It would go and it would lead to further activation of your macrophages, leading to granuloma formation. It can go activate your natural killer cell, CD8 positive T cells, right? You guys can see it here. Okay. And it also causes IgG isotype class switching. That's something you have to memorize, okay? Interferon gamma. But you guys know the concepts now, right? I think it would be easy for you guys now to know things, right? Interleukin 4, we know that in order to activate the Th2 we need interleukin 4. And once Th2 is activated, we have B cells coming out, right? So can I say it promotes B cell growth, and B cells once come out, it's going to undergo class switching, IgE and IgG, right? Hello?
Yes, sir.
Okay. For the interleukin 5, keep that in mind. A lot of MCQs from you world. But interleukin 5 do it's again going to come from Th2 cells, right? So it's basically going to okay. Okay. So the interleukin 5 is going to attract eosinophils. That's really important, right? Really important. Where do we see an eosinophilia? A lot of places, right? In asthma, we were seeing eosinophilia, right?
In parasite
And okay,
infection also.
eosinophils basically is going to be seen in parasitic infection. That's something which you have to keep in mind. You have a UWorld MCQ, something called cystosoma, right? That's a parasite, right? In order to fight against that, we need eosinophils. So which interleukin do we need? That's interleukin 5, right? It's going to release something called the major basic protein, right? To kill off that parasites. Is it clear?
Yes, sir. Sir, what is the relation when there is adrenal insufficiency? There is also eosinophilia.
If there
And
is,
there
Yeah.
is Addison disease, no? Adrenal insufficiency. There is also eosinophilia.
okay,
What is the
okay.
concept of this?
Eosinophilia can be seen in allergic reactions, hypersensitivity reactions as well, right? Allergic or hypersensitive. So in adrenal insufficiency, that's basically going to be, autoimmune destruction, right? It autoimmune diseases, right? Hello? And which hypersensitivity is
Yes.
going to be that? Hello?
Autoimmune
Type 2.
in developed,
Type 2, yes.
Oh,
He
that's
had that.
type 2.
but it is due to TB.
Sorry?
I'm just asking that the okay. Well, you were discussing about the condition, the Addison disease, right? In which all of the
Yes, yes. What is the relation when there is eosinophilia also?
okay. Let me just tell. There can be a lot of relations, right? Okay. First of all, how do we get the adrenal insufficiencies? There isn't only the one reason Addison's. Okay, one
Two
of them can
causes
be.
are one is
Mhm,
autoimmune in developed country and in is hemorrhage like tuberculosis in
mhm.
underdeveloped countries.
Okay.
Yeah.
We can also have some hemorrhagic infarction, right? Can you
Yeah.
guys
What?
tell me the name of that?
Yes,
Perhaps.
the pneumococcal.
Waterhouse. Okay,
What?
gonorrhea. There's something with gonorrhea.
Skin.
Waterhouse Friderichsen syndrome. Do you guys know that?
Yeah.
Yes.
Yes, sir.
Okay. Okay, so that's basically type 4 hypersensitivity. Whenever we are okay, let me just ask you a question. You guys might have done a lot of UWorld MCQs, right? Whenever you have a history of, if they're asking you, let's suppose Addison disease, so they might have mentioned two or three other things, right? For example, Hashimoto's, they might have mentioned that. They might have mentioned that this individual can have type 1 diabetes, right? Hello.
Yeah.
That means,
So
sir,
all
it
of
is
those,
autoimmune,
yeah,
Yeah.
it's an autoimmune
Basically,
condition,
yes.
right? A type 4 hypersensitivity in which your T cells are destroying that, right? All of the things, right? Hello?
Yes, sir.
Okay, so in
That
these
is.
type 4 hypersensitivities and in these reactions, we can have eosinophilias. Like eosinophils are basically, the lines of your immune cells, right? They can just come if you have interleukin 4 release, interleukin 5 release, and they can lead to, like, somehow lead to destruction. They can be the component, as they are the component of your immune systems, and immune systems and immune cells in that condition are destroying different parts of your body. Like in type 1, they're going to destroy. So in this way, you can just keep in mind that they are basically part of your immune system, right? So they can come. You can see eosinophilia. Like for example, in asthma, right? We do not have any parasitic infection, but still we have eosinophilia, right?
Yeah.
Right?
Yes.
That's a type 1 hypersensitivity,
Yeah.
right? So all of these immune cells are basically connected. You can see, like, you cannot always follow the conventions, but at least you can just make sense out of these things. Okay?
Okay, sir. Thank you.
Awesome. So then we have interleukin 10. They are okay. What are the function of interleukin 10? Do you guys have any idea?
It's an anti-inflammatory.
Anti-inflammatory. Everything we just discussed now was what leading to inflammation, right? Interleukin is going to be anti-inflammatory, and the idea is really simple and really same as we discussed in complement system. We discussed how to activate complement system. In the end, we discussed we have something C1 esterase inhibitor which keep on regulating your complement system in order to look if we have exaggerated response of exaggerated activation. Same is that with interleukin 10. In order to look, or in order to modulate or regulate the activity of your complement system, no, sorry, your inflammatory cells, you have interleukin 10, which is anti-inflammatory, which would decrease the T cells whenever in the case if we have increased activation of T cells. Is it clear? Hello?
Yes, sir.
Okay. And the last one is interleukin 13. It's going to produce IgE, right? So interleukin 5 was also making your IgE, right? And you guys know in type 1 hypersensitivity, type 1 hypersensitivity, we discussed that we need IgE, right, in order to sensitize your mast cells, right?
Yes.
And there again we were having eosinophilia, right? So again, like you can just think of that's a type 1 hypersensitivity, but still, an allergic condition can have eosinophils, right? So you should just keep that thing in mind. So IL-13 is also important for IgE production. Class switching B cells giving us IgE, right? So 13 double EN for IgE. Okay. And TGF beta, that's also really important. TGF beta is also an anti-inflammatory. IL-10 and TGF beta. Okay. Is this page cleared?
Yes, sir. Thank you.
Okay, so I just tried my best to make sense out of all of these things, since it's a pure memory, right? But also now things are clear. Okay, okay. So we are left with okay. So let's start vaccination, and in the end we are going to do this respiratory burst. Okay, okay. Let's do interferons. Okay, one of the doctor. Okay, interferons alpha and beta. We discussed interferon gamma. You guys know the concept, right? It's coming from where? It's going to come from your TH1. From
TH1.
where do we
Macro.
get interferon alpha and beta? Whenever we have a virally infected cell, a cell being infected by a virus, that viral infected cell can make interferon alpha and beta. That can just go into the other cells, surrounding them and telling them that we have virus. Just please do something to save yourself. Do something to save yourself, right? And what was one of the mechanism from saving, cells from destruction? That was your MHC1. Remember? Hello? How do
Yes,
we
sir.
destroy cells in a viral infection? We discussed That cells are going to break down the pieces, present it on MHC1, CD8 positive is going to come, it's going to lead to destruction of the cell. We discussed that, right? But if one cell is already virally infected, it would just make interferon alpha and beta. They're going to go into the surrounding cells and tell them to just, something, wrong is going on with that cell. Just try to, keep yourself, safe from the viruses. And how do viruses basically infect? You guys know the basics, right? They hijack your molecular machinery, right? They would hijack your molecular machinery. They would just hijack your entire system and make proteins of their own. They're really clever, right? They would just go that would just go into your DNA. They are going to become the part of your DNA, and they are going to use your own messenger RNA, your ribosomes to make viruses. Right? Hello.
Mm. Mm.
Okay.
Yeah.
So what these interferon alpha and beta, first of all, they're going to go into the cell and they're going to tell the molecular machinery to slow everything, slow down everything, because soon you are going to be infected by. You have the chances to be infected by the virus. They can use your machinery, just close the machinery, decrease the activity of machinery, you know. So it's going to decrease the replication. It's going to tell them decrease, do not present any MHC1, right? Decrease that because you are going to soon going to be killed by your CD8 positive CT cells. Okay, so is it clear?
Yeah.
Hello. Okay, so in
Yes.
this way, the interferons are going to save the surrounding cells from this viral infection. The clinical use, Kaposi sarcoma, we're going to be this. You guys know that the Kaposi sarcoma seen in the HIV, right? The cell here is cell leukemia, condyloma cuneatum. That's going to be a topic of your reproduction, renal cell carcinoma. You guys already know that, right? Okay, the adverse effect can be fluke-like symptoms, depression, neutropenia, myopathy, interferon induced autoimmunity. Then that's very simple. That makes sense. If you are decreasing the activity, of a lot of cells, so what would happen? It would just lead to less muscle formation, less neutrophils formation, and interferon induced autoimmunity that can lead to production of of antibodies that can cause problems to your body. So that's something which you should just keep in mind. Okay.
I have a question, doctor.
Yes, please.
Um, I overheard that there is no medication to kill viruses. Why is that,
Mhm.
please?
Okay. The reason behind that is that your viruses just go, they become part of your DNA. If I'm killing the virus, I'm killing your DNA as well, right? The viruses are basically going to, squeeze their DNA into your cell. Their DNA is going to be coming the part of your DNA. They're going to come, they're going to sit there. I do not have enough technology to kill specific part of DNA. I can kill the entire DNA in order to kill the virus. So if I'm killing the DNA, I'm just killing the virus along with my own DNA. So that would be a poor approach, right?
Yes. Thank you.
Okay. Okay. You're welcome. So, okay, active and passive immunity. So, okay, so tomorrow we are going to discuss this vaccine, or either we can have a 10 minutes of break and then we can just start this vaccination topic. Okay. Are you guys
Okay,
Yes.
sir.
enjoying the session?
Yeah,
Yes.
better 10-minute break, then
Yes.
we can start.
Yes.
Yes, thank you so much.
Hello.
Yes. Yes, sir.
Hello. Are you guys able to hear me? Hello.
Yes,
Hello.
Hello.
sir. Yes, Doc, we're
Yes,
hearing
sir.
you.
Okay. Perfect. Let's start our vaccination, right? Okay. So for the
Doctor,
vaccine,
I have a
yes,
question
yes, please.
about interferon.
Mm-hmm.
Can you please summarize in 2 lines?
Okay. What? For interference?
Yes.
Okay. So interferons, we have interferon gamma, we have alpha and beta, right? The gamma, alpha and beta, they are like entirely different from one another, right? So the alpha, the alpha and the beta are like same, while the gamma is entirely different. The gamma is going to recruit your macrophages. It's going to lead to Th1 response. That's a separate thing. The other alpha and beta are going to help the other cells in order to be, okay, it isn't a single line. Really sorry for that. Okay, so alpha and beta basically is going to save your cells, your surrounding cells from viral infections. Okay, they are being secreted by the viral cells, and once they are secreted, they are going to save the surrounding cells from this viral infections. That's all.
Okay. They are
Okay.
basically secreted from viral infected cell.
Yes. Okay. So let's discuss vaccination, right? Okay, what is vaccination? Okay. As I already told you that, okay, first of all, you should have an overview of active and passive immunity, right? What is active immunity and what is passive immunity? The passive immunity is anything like, it's a kind of spoon feeding, right? Passive immunity is a kind of spoon feeding, while active immunity requires a lot of, effort. Okay. The main goal of both of them is to give you immunity. What do we mean by immunity? Immunity is saving your body from foreign infection, foreign particle, foreign pathogens, right? So in case of passive immunity, we are directly spoon feeding an individual. We are giving them whatever they need, right? For example, we can give them IgA. IgA is really important to fight off mucosal infections, right? So it's going to directly go and it's going to fight off the infections. For example, if you guys know, if someone is bitten by a snake, you know what is the anti-venom? The anti-venom is basically being produced by the horse body, right? Anti-venom antibodies. So that's also going to be an example of passive immunity. If you are directly getting those antibodies from the horse and injecting into this individual, that's going to provide immunity. We are just spoon feeding him, right? Those antibodies are directly going to go. They're going to take the venom, right? Snake venom. What is active immunity? In active immunity, basically we are training the immune cells. We are training, it's like an entire training process, right? We are training the immune cells, and once they get trained, they then know how to fight. Before fight, you must be trained well, right? So that's your active immunity. How do we train someone? You know, for example, if you have an army, how do we train? We do some mocks, we do some drills, we just create a kind of, real fight environment for them. So they are going to be well trained, right? Okay. So how do we train our immune cells? We are going to create an environment somehow near to the real war. Somehow that environment is going to be, correlating with the real war. So infections and providing vaccines, right? They can train your immune cells. We are creating an environment where they can be trained well. So in the future, if they have a real war, they can perform well. Is it clear? Like, how can we just train an army? You can have a minor battles, right? That's going to be a good training approach, right? So natural infections, and you can also, if you want to prepare them for a war, you have to create a scenario for them, more harder, right? So in that way, they can be just well trained, and if by any chance they get into the war, they can fight well. So vaccination is training. Vaccination is training, right? How do we train them? Just infect them or just give them vaccines. Okay. So what is the concept of vaccines? Let's discuss life attenuated vaccines. How do I train? Okay, for example, what I would do, I would just take for example, if I want to train myself again or train anyone against a virus, right? So what I would do, I would, for example, take that virus, right? For example, if this is the virus, right? Okay, and for example, if this is the component of the virus, a specific component of a virus which is really toxic, so what I would do, I would just remove that component of virus, right? Because I do not want a real war. I do not want real war. I need training, right? So, for example, I want to, fill the guns with real bullets. I have to fill it with, that rubbery bullets, right? So we have to remove these component of viruses, right? Which are pathogenic, more pathogenic. And we are inject the other virus, we are going to inject the other virus into the body. Okay. So as this virus is injected, we can have two pathways we know. For example, if this is your dendritic cells, either it can be either it can be engulfed, it can be presented on MHC2, right? Presented onto your CD4 positive T cells. They can give you to your Th2 response. They can give B cells response. B cells have memory, right? They can give you IgGs. IgGs have a kind of memory which can fight off the future infections. This can be one of approach. So as we have memory B cells, memory T cells, they know the memory. Now they know how to fight. They know how to fight this. Already this bug isn't going to cause the real problem because they have rubbery bullets. They do not have the real bullets, right? So as they get trained, so if the same bug with this with the real bullet attacks them, they have the memory, they have the training, they're easily going to tackle them, right? Okay. Hello. By IgG and memory B cells. Is it clear? The other thing is that, for example, if I'm giving this pathogen, it can infect the cell, right? It can be intracellular, and once it infects the cell, we know that it can be presented on MHC1, right? Hello? And from the MHC1, CD8 positive cytotoxic T cells can come, and T cells have memory, right? So in both of these cases, if you are infecting a cell, or if you are, using the cell as antigen presenting cells, in both of those cases, you are training these cells because in the end, they are getting memory. You know what is a good training? In the end of good training, you have the memory, right? Memory is going to help you. I know how to fight. If I know how to fight him, it means I have that memory. No, I know. Okay. So that's a concept of your your immunity. So what do we do in life attenuated? That we weaken the organism. The organism is live, but we removed the real bullets. We just only load our rubbery bullets into that, right, in order to train them. So here you can see, okay, live attenuated vaccines, since they are real organisms, so we won't give it to those individuals who have weak immunity, or either who do not have immunity. You might have discussed it with Dr. Moaz, that is severe combined immunodeficiency, in which we do not have B cells and T cells. If you do not have the soldiers, so how can you do training? You can't train anyone if you do not have the soldiers, if you do not have B cells or T cells, right? So you cannot undergo training. And if you are giving that bug, even that weakened bug can cause infection. It can cause problems, right? Even in the infant as well, as one of the doctors asked me an MCQ. The army there is, still a baby army, right? It's a baby infant army. Once they get mature, then we have to train them. So the training requires a specific age as well, right? Okay. The other thing which you should just keep in mind, HIV. HIV leads to immunocompromised state, right? Because it's going to target your CD4, the CD4 helpers count are going to come down. But we have a reference number which we have to look for, right? If the CD4 count is equal to or greater than 200, we can give live attenuated vaccine, because still they have those sufficient army which can be trained. But if it's less than 200, it means the army number is less. So, there are a lot of factors which are important for this training process, right? First of all, you must be having, good amount of army, good number of army, right? Secondly, the army, the soldiers must be some, at some maturity level to get them trained, right? And they must be, given, life attenuated. Okay, and absent soldiers. If you do not have absent soldiers, so in those you cannot give these vaccines. It can cause problems, right? So here you guys can see that what are the pros. Okay, so induced cellular and humoral response. So in this case, you can see that these viruses have the ability, or these bugs have the ability, as they are live, They can infect the cell, and infection of the cell is going to give us T response. T is a cellular response, right? Hello? Are you guys listening?
Yes, sir.
Hello?
Yes.
Yes.
It's a cellular response, right? And they can activate MSC B cells. That's a humoral response. So with live attenuated vaccines, what's the best thing? We can have a strong memory, a strong training, right? A strong training. Both your humoral cells and both the P cells are going to be trained well. Does that make sense?
Yes, sir.
Hello? But what's the problem with the with these live viruses? The viruses sometimes keep on mutating themselves. What if I just cut this part, this pathogenic part from a virus? Sometimes it like still it is live. It can make things. It can survive itself. For example, if I cut this part and I inject it, it already have proper machinery. It can just make it again. Once it's in your body, and what if it make it? So instead of training, you are just creating a real war situation, right? So that's the problem, right? Is it clear? So
Yes, sir.
let's discuss the examples of live attenuators. So mnemonic they have mentioned really good. That is, attention, teachers, please vaccinate small, beautiful. Okay, it's not young. It's yellow infants with MMR routinely, right? It's not young. Okay, so attention, adenoviruses, right? It's alive. Typhoid, again, it's alive. But here you have a point which you have to mention. Typhoid vaccine once given orally is the live variant. If you are giving it IM, that's a dead variant, right? Or the killed variant. Is this clear? Hello?
Yeah.
Yes, sir.
Okay. So you should just, mark these points as well, right? If in a questions time they are mentioning an oral vaccine, so you should know that oral is alive and IM is a killed, right? The other one is polio, right? The polio is Sabin. Sabin is really important because the Sabin is live while the Salk is dead. Okay? Okay. Smallpox, PCG. Okay, I just told you it is a yellow infant, right? Not a young. So yellow fever, influenza, but influenza intranasal is alive. Influenza intramuscular is killed. Is it clear?
Yes, sir.
Okay. BCG, MMR, and rotavirus, right? That's all. Is it clear? Hello?
Yes, sir.
Okay. For the killed and inactivated vaccines, we know how do we kill a pathogen? Okay, so there is a difference, right, in pathogenicity and immunogenicity, right? Like in this case, we are removing the pathogenic component of a bug. Still, it is immunogenic. I'm removing the pathogenic portion, but it is immunogenic. It's good for training. It can train. It can train yourself. So immunogenicity basically means that either can it train yourself or it can't train yourself. So if we kill a vaccine, right? If we kill a bug and use that as a vaccine, although we are destroying the pathogenicity, but still it is immunogenic. Still you can train the body with it. Is this concept clear?
Yes, sir.
Hello? How do we kill a bug chemically or with heat or with chemicals? Just kill it. Once we just kill it, since it's still immunogenic. You can use it for training purposes, right? Just give it, safer than live vaccine. We know that it's killed, right? Okay, but you're gonna get weaker cell-mediated immune response, right? Cell-mediated immune response. So, what was your cell-mediated immune response? The T cell response, right?
T cells.
Okay, so the T cell response can be there, right? Okay, and mainly induces your your cell mediated weaker cell mediated mainly induces a humoral response. And what's the reason behind that? We have weaker cell mediated and good humoral response. The idea is really clear because we discussed that mediated comes whenever you infect a cell. You know, the cell mediated CD8 positive was coming whenever you were infecting a cell and it was presenting everything on MHC1, right? Infection, remember? That was infection, right? Hello?
Yes, sir.
Hello. So the killed cannot infect a cell. We know that. So this component is finished because it's a killed. Killed cannot infect a cell. It means that this one is going to the humoral is going to be mainly same. But since the level of training isn't that sufficient, because best training is both humoral and T cells. So what we have to do, we have to provide these trainings every 6 months, every 10 months, in order to keep their memory fresh, right? So for that, we have to give booster vaccines, right? Now, booster doses. So booster doses, the concept is only to keep remembering them the training process, to get not continuously getting them into the training process, so that they cannot forget the training, right? Is this concept clear?
Yes, sir.
Hello? Yes. Okay, so the hepatitis A, typhoid, rabies, influenza, polio, and no a trip can kill you. Simple. Hepatitis A, typhoid, but not intra. Okay, not oral. IM. Rabies, influenza, not intranasal. IM. Polio, not the same in the heart. That's a good one. Okay, is it clear?
Yes.
Hello. Okay. So for the recombinant, we
Sir,
discussed.
it's also one, I think, the contraindication. If it's a very serious disease like rabies or tetanus, we cannot give the live attenuated agent.
Yes. Yes.
Hmm.
Yes. Okay. So if you want good training, good training is basically for more severe wars, right? Huh. So for that you have to give the live one, right? Okay. So the concept is same. Okay. Then the subunit and polysaccharide. For the polysaccharide, I just did this entire vaccine. If you guys remember, let me just give you a small overview, right? We discussed that only peptide components can be loaded into MHC2, right? So if we load polysaccharide, if you get polysaccharide as a training process, so you can get these TH independent B cell activation. That's an IgM very weak response. So for that, what should I do? Either I should just give booster doses, but the clever method is to just add some peptides into that. And as you add some peptides, then the humoral immunity IgG can come. In this way, you are just keeping the memory for a long time. Is it clear? Hello?
Yes. Conjugate vaccine. Yes.
Conjugate vaccine. So we are conjugating it with some proteins, so in order to get good, humoral response, right? Okay. So what are the examples? The example here are, first again, memory, HBV, acellular pertussis, Neisseria meningitis, Streptococcus pneumonia, PPSV23 is a polysaccharide, more weaker, right? But PCV13, PCV15, PCV is more good because it's a conjugate vaccine. And once we have conjugated vaccine, that's basically TH dependent activation of B cells, which is more good, right? Is it clear? Hello?
Yes.
Okay. So let's discuss the last one, mRNA, and then I'll be discussing this toxoid one, right? The mRNA is really simple. And this, what we do, we give mRNA, messenger RNA. You know what's the function of messenger RNA? In normal body, that it go into your ribosomes, it get translated, and it gives you proteins, right? Okay. So instead of giving, let's suppose, in case of COVID, right? Okay. For example, if this is a COVID, virus, let's suppose. So we have something called spikes, you know, and these spikes portion of the COVID are really, the dangerous one, right? So, these are the main, the main component of the virus, which is really deadly. So instead of training your immune cells to this entire virus, let's specifically train them against the spikes. Does it make sense? Hello?
Yes. Yes.
So how do we train them just against the spikes? We know that we have messenger RNA, right? Messenger RNA make proteins. So we would take the messenger RNA for these spikes. Those messenger RNAs which are basically encoding these spikes, we are going to take those messenger, inject into the body, and those messenger RNA are going to use your own ribosomes to give you off the spikes inside the body, right? And once we get the spikes, we can have either humoral or T cells immunity, right? So that was basically your mRNA, right? So here you can see that It's very specific, highly effective, right? But it can cause a lot of problems. You have to memorize that, right? It can cause a lot of problems. Like, for example, transient systemic fatigue, headache, myalgia, myocarditis, pericarditis, in young male especially, right? So sometimes that spike portion can be really deadly for you, right? You might have seen these cases after the COVID, right? That young male are dying due to some cardiac problems with pericarditis, with myocarditis, inflammation of heart. We have fatigue. You guys might have experienced that after the vaccination, right? There were a lot of myths as well, that. Okay, so you can just notice that myocarditis, pericarditis. So these can be some side effects, right? And I think that our generation should, it would be quite easy for them to memorize these things regarding the COVID, right? So that's all
Yes, sir.
about mRNA. Okay, the last one is toxoid. Okay, so what do we do in toxoid? We discussed that we are going to give some bugs. In the toxoid, let's just be more specific. What's causing problem in tetanus? We have something called tetanus spasm, right? That's a main problem. That's the main culprit, right? Which causes problems. So instead of giving the entire bacteria and waiting for it to produce, the tetanus spasmin and tetanus spasmin itself, the fear of getting tetanus spasmin, causing the real infection. So what we do, we are directly going to take the tetanus spasmin, remove the bacteria, the bug, because it makes the tetanus spasmin, which is more fatal, right? Take the tetanus spasmin, kill it, but only leave the receptor on the surface of it, right? Because the receptor are immunogenic. You can train your immunity without those receptors. Is it clear? Denature the bacteria toxin, just leave those receptors on the surface of those toxins, right? So what's going to be the pros? It would protect you against the bacterial toxins. What are going to be the cons of this? You can have antitoxin level decrease with time, right? The antitoxin level can just go less with time. So for that, we have to keep on reminding again and again your body with booster doses. Does it make sense? Hello?
Yes, sir.
No, I
But
said
sir,
it's going
the,
to
the
activate.
toxins are also proteins, and
They
we
are
know that they have
proteins,
the
so they are going to
yes.
give B cells,
Hmm.
they're going
But
to
it's
give you
also
B
have a good
cells.
immune response. But we have to give the booster also.
Yes, we have to
Yeah.
give a booster also, right? Because, like, the perfect one was your life, if you remember, right? Because you're just training the entire aspect, both the humoral and both the cellular. And for the
Cellular.
cellular, we need a kind of infection. But since you're killing the toxin, the receptor cannot cause infection. They can train your B cells, right? So for that, we have to keep them into the training again and again via booster shots. That was all about vaccination. Did you guys enjoy the session?
Yes, sir. Thank you.
Okay. Thank you so much. And if you guys have any kind of problem within these topics, within anything, so you can just mention in the group, and I'll just try my best to do it, right?
It was
So,
a very good session. Thank you so much.
Thank
You're
you.
welcome. Thank you so
Thank you
much.
so much.
Okay, so
Thank
you
you.
guys don't have to get panic. We are gonna end everything on time. You guys have me on the back. Don't be worried. Okay.
Okay, sir. Thank you.
Thank you
Thank you
so much.
so
Sir,
much.
Thank you.
I have a doubt. One last doubt.
Yes, please.
This polysaccharide vaccine conjugated is recommended in splenectomy patients. So, how do splenectomy patients get the antibodies to this vaccine? They don't have spleen.
Mm-hmm.
So,
Okay.
how are they generating immune response without spleen? A good
Okay.
response.
Okay. So, we discussed that spleen is mostly going to give you your IgM, right? If you guys remember, we discussed it
Yes,
indeed in the spleen, right? But since
yes,
you
yes.
have your lymph nodes, there you have follicles, you still have B cells, right?
Correct, correct. So, it's from the other lymph organs, basically.
Yes, from the other
Okay.
and the immunity, basically the strong immunity is your IgG, right? Not your IgM.
Yeah, yes, yes, yes. Got it. Got it. Thank you. Thank you.
Okay, thank you so much. Thank you and have a nice. Bye bye. See you guys tomorrow. Okay. Bye bye.
Thank you.
Bye, doctor. Thank you.